In this video, we demonstrate a revision meniscal repair with amniotic membrane augmentation. The patient was a 16-year-old female with failure of her meniscus repair performed 2 years prior. MRI demonstrated a re-tear of the medial meniscus correlating with her recurrent mechanical symptoms. The patient's parents were consented for revision meniscal repair with amniotic membrane augmentation in an off-label use. Viewing from the standard anterolateral portal with a 30-degree arthroscope, friable tissue is visible at the previous repair site. Probing reveals failure of the meniscal tissue to heal, but no undersurface tearing. Percutaneous medial collateral ligament trephination under valgus stress improves visualization and room for instrumentation. Suture was removed from the prior repair, and a probe was used to gauge the length of the tear for amniotic membrane implantation. Then, friable tissue at the tear site was removed with an arthroscopic shaver to prepare for amniotic membrane insertion and subsequent healing. Rasping the capsule and tear site stimulates angiogenesis and promotes the healing response. The delivery device, sealed amniotic membrane, and sled for device insertion are shown. Graft preparation was performed on the back table. Dry gloves are used for initial handling of the amniotic membrane, since the tissue becomes tacky once moist, making it difficult to insert through the slot of the delivery device. Once the membrane is gently pulled halfway through the slot, it is moistened by hand and folded in half in line with the delivery device. The thumb slide plunger is then slowly advanced to avoid cutting the membrane and is then ready for insertion into the meniscal tear site. Insert the delivery device tip through the standard anteromedial portal over a sled and into the repair site. Carefully advance the thumb slide plunger on the delivery device to deploy the implant. Upon retracting the delivery device, the amniotic membrane is left behind inside the repair site. Probe any extruded implant so that it is entirely within the repair site. Utilize meniscal-based suturing to achieve vertical compressive forces, in this case with all inside sutures. Then, perform capsular-based suturing for horizontal compressive forces, this time with all inside knotless sutures. The final repair demonstrates appropriate tension without meniscal extrusion. Finally, perform bone marrow venting with a microfracture awl in the intercondylar notch to augment healing of the repair. Toe touch weight bearing is allowed for the first 2 weeks before progressing weight bearing by 25% per week until bearing full weight at 6 weeks. Range of motion is allowed from 0 to 90 degrees, starting at 2 weeks when non-ambulatory, and blood flow restriction therapy is initiated. Progression to impact activities begins at 12 weeks, with return to sport between 4 to 6 months. Planned MRI at 6 months postoperatively shows evidence of healing, with no evidence of re-tear or meniscal extrusion. Clinically, she had returned to playing recreational tennis.